I'm sorry.
Be alive.
Good evening, everyone. Welcome to lecture 29 of iFocus. Today's topic is viral keratitis, and it is being taken by Dr. Varun Malhotra, sir. Dr. Varun Malhotra is a consultant at Center for Sight for Cornea, Cataract and Refractive Surgery. He's a very humble and a genuine person and has a great passion for teaching. Over to you, sir.
Hey. So, thank you, Ankita, for the very flowery introduction you gave me, and welcome to all the students who are here to hear me out. You just share my screen and we would then start the lecture. Right, so Ankita, can I start?
Yes, sir.
Hi. Right, so today I'll be speaking about the concepts in viral keratitis, and it's very important to understand that a textbook approach does not apply to all the cases. The therapy has to be titrated based on each and every case, and obviously as you see more cases and you become more experienced in your field, you understand what to do when. So I would just like to share some of my experiences all this while. Yeah. Slides are not moving, Ankita, now. So, Sunil ji?
Just click on the screen, sir. It should move.
Okay. Yeah, thank you. So the global incidence of herpes of the HSV keratitis is roughly about 1.5 million cases every year, including 40,000 cases, which keep on getting added up, and they cause severe monoocular visual impairment or blindness every year. So humans are the only natural reservoir for the herpes simplex virus. The infection is generally spread by direct contact with the lesions and the secretions from these lesions. Now, basically what we are trying to say is that the virus is very infective and it can get transmitted through infected hands, or in case if you share the tonometers. It has been found that almost 60% of the children get infected by the age of 5 years. At autopsy, nearly 100% of people who are more than 60 years are found to harbor HSV virus in their latent phase. Now, the HSV virus is basically an enveloped virus, and these enveloped virus are very, very susceptible to the ultraviolet light, detergents, alcohols, and different types of broad spectrum antibiotics. And therefore, their infectivity is very short-lived outside the human host. So it is actually very difficult to transmit the HSV infection via the fomites and by sharing the medical instruments if you keep on disinfecting them regularly. And alcohol treatment should be enough because these are lipid enveloped viruses and they are very, very susceptible to any kind of alcohols and detergents. Now so first I would just tell you the morphology of the virus. It's a linear double-stranded DNA virus. The size is 150 to 200 nanometers. It is surrounded by a protein coat capsid and by a lipid envelope, which generally has viral glycoproteins. These viral glycoproteins, which are there on the lipid envelope, are basically have the antigenic activity also. Now, there are two different types of viruses, HSV1 and HSV2. Broadly trying to demarcate, the HSV1 infections occur above the waist and HSV2 below the waist. So the type 1 HSV viruses mostly lead to orofacial lesions and ocular lesions. The type 2 virus generally leads to genital lesions. So the HSV virus as a primary infection tends to infect either the eye or the skin. It can get infected through the pre-existing lesions from people who are already infected, tends to replicate itself in the epithelium, infects the subepithelial corneal plexuses and reaches the trigeminal ganglion, where it can harbor itself in a latent phase. Now, whenever there is a transient immunocompromised state, so you may have cough, cold, fever, any other viral infections, whenever the immunity level goes down a little, these viruses tend to reactivate, they replicate and spread through the trigeminal ganglion. So the virus is basically harboring itself in the Gasserian ganglion or of the trigeminal nerve, and it can basically spread through all the three branches of the trigeminal nerve, namely the ophthalmic branch, the maxillary branch, and the mandibular branch. Ophthalmic branch of the trigeminal nerve is the most common route of infection, and that is how it causes recurrent infections in the cornea. So now I would just classify the ocular herpes simplex complex. So basically the ocular herpes can be classified as congenital and neonatal, primary ocular herpes, and recurrent or reactivation. Well, it's very important to understand that this herpes virus is a neurotrophic virus, and therefore these neurotrophic viruses have the capacity to establish themselves in the ganglions in a latent phase and keep on reactivating over a period of years. And obviously you can find these infections going on reactivating almost 15 to 20 years after the primary lesion or primary episode. So first of all, the congenital and neonatal ocular herpes. Now it can be acquired during intrauterine, peripartum, or postpartum phases. The intrauterine infections are very, very rare. They generally do not cause keratitis. My talk today is basically about viral keratitis, so I would not be focusing too much on this, but just to tell you, the ophthalmic features can be, as you can see here, microophthalmia associated with a microcornea, can be retinal dysplasia, a primary optic atrophy, and a chorioretinitis. The skin lesions and neurological lesions are very extensive in cases of congenital and neonatal herpes. The ocular lesions are not very extensive. The peripartum and the postpartum infections form 80% of congenital herpes. Most commonly, skin, eyes, and mouth are affected. Generally, the vessel involvement is not very life-threatening because of the maternal antibodies which are transferred to the baby transplacentally. However, in case this happens, an emergency IV cyclovir treatment, 8 milligrams per kg, has to be started to be repeated every 8 hours. So coming on to the primary ocular herpes. Now, generally, primary ocular herpes affects an individual after the age of 6 months. That is when the maternal antibodies tends to decrease and starts to come down. It generally is like a flu-like illness. 94% of the people who are having a primary infection do not develop ocular lesions. And as I earlier told you, by the age of 5 years, 60% of the individuals are already harboring the virus, and they do have a subclinical infection in place. Now, primary ocular herpes also starts as a blepharoconjunctivitis. The typical presentation is involvement of the eyelids and the conjunctiva. So it's a very typical follicular like lesions which are present in the inferior fornix, and that is why you may confuse it with an adenoviral conjunctivitis. So what tends to differentiate these lesions from the adenovirus? Can anybody tell me? I think it's already there in my slide also. Ankita, who can answer?
Aziba, can you answer? Aziba, you're there?
Yes. Yes,
Yeah.
ma'am.
Follicles.
Yeah,
Yeah.
Piyush said.
No, the follicles are already there. The typical presentation is follicular both in a primary ocular herpes and even in an adenovirus. So how will you
Membranes,
Congestion won't.
the congestion on the membranes on the
Yeah.
conjunctiva.
So the clincher here is the membrane. So the pseudo membranes or the conjunctival membranes are very extensive in adenovirus, and they're generally absent in the herpes virus, right? Also, you will have periocular skin lesions, involvement of the lid margins. You will have lid margin blisters. In very late stages, these may get ruptured and they may suppurate. They may lead to scarring of the lid margins, enrolling of lid margins leading to an entropion. You may have tracheitic lashes. They will rub onto the corneal surface, and that is when the cornea starts to get infected. So the corneal lesions per se in a primary ocular herpes in most of the cases may be secondary to the lid lesions, right? And as a rule, the primary ocular herpes always confines itself to the epithelium. There is absence of stromal involvement as the host is not immunologically programmed for a reactivation or an immune mediated response to the attenuated virus, because the infection is happening in the susceptible individual for the first time. So this infection is epithelial. It will go on and harbor itself in the trigeminal ganglion, and later on in his life, this live attenuated virus will post a reactivation. Generally, the primary ocular herpetic diseases are self-limiting and they healed by themselves. Only in case, as I told you, in cases of a CNS involvement, you may have to give an emergency IV acyclovir. The workup of these cases is important. The history is the clincher in these cases. In recurrent cases of herpes, and history of a previous episode may help you to reach the diagnosis. External examination is important to look for lid margin blisters, to look for subsequent scarring of the lid. A slit lamp examination. The IOP measurement is to be avoided in any epithelial lesion. However, if the stroma is involved, you can actually go ahead with an IOP measurement also. Check corneal sensations before you put a topical anesthetic. And laboratory diagnosis has very limited role or very limited value in recurrent herpetic lesions. Also in primary herpetic lesions, you see, basically in a case of ocular herpes, the lesion is by and large clinical. Only in those cases where you are confused or you have superadded infection, the indication for a lab diagnosis is very less. So also in cases of primary ocular herpes, if you are unable to, decipher the cutaneous lesions, and you may confuse it with a skin infection, so something like an erysipelas where you have similar lesions of the skin, then you may think about a lab diagnosis. So in case you decide to do a lab diagnosis, then you have to take scrapings from the edge of the ulcer in the cornea, or you can rupture one of the vesicles and collect the material from the base of the vesicles and send them for a GMSA staining or a Papinicolau stain, where you may find very typical inclusion bodies. You can send a serum antibody testing to look for the virus, but it has no value during the recurrent diseases because your serology will already be positive because of a latent virus or a pre-existing primary exposure to the virus. You can actually directly demonstrate the virus by electron microscopy, but then most of the centers in India do not have it. You can do a viral culture nowadays on the chorioallantoic membrane. You have special cell line cultures like Vero cell culture, EK21. But the most important here is the polymerase chain reaction. And I'll tell you, basically in my clinical practice, what I've seen is that most of these patients who come to your clinic are already on this cocktail treatment or masala treatment, because in most of the places, these patients are on antibacterials, antivirals, antifungals, and it is very difficult to be able to isolate the viral strain on the scraping sometimes. So the polymerase chain reaction is a very good tool for that. And whenever in doubt, I generally send for a PCR. So you can actually send a tear sample with the help of a pipette. You can actually scrape some amount from the corneal epithelium, and AC tab will also harbor the virus in cases of keratouveitis, wherein there may be an AC reaction. And as you can see on my slide here, a PCR has very high sensitivity and specificity value. So coming on to the most important part now, because the diagnostic dilemmas are very high in cases of treatment of recurrent herpetic keratitis. So a recurrent herpetic keratitis can be epithelial, can be stromal. Stromal can be non-ulcerative and ulcerative. Herpetic iridocyclitis or keratouveitis, as we call it, and metaherpetica, which is a neurotrophic keratopathy. Now, HSV epithelial keratitis. Now, the epithelial keratitis is the most common form of presentation of a HSV infection of the eye. Now, generally, the herpes simplex viral infections start as superficial punctate keratitis on the corneal epithelium. They cause various erosions which are formed in clusters and crops, and they keep on recovering over a period of time until and unless they start coalescing with each other to form a lacy dendritic ulcer. Now, this is a shallow ulcer which generally tends to involve up to the basement membrane along with the terminal bulbs. The patient generally complains of photophobia because of the epithelial breach, redness, there is some amount of ciliary flush, and of course, blurred vision. Now, when you stain a true dendrite, the base stains with fluorescein because the epithelium here is absent. The fluorescein basically diffuses into the stromal tissue, and the stromal tissue basically stains with fluorescein. On the contrary, the terminal bulbs have heaped up epithelial cells. They have devitalized dead epithelial cells where the virus is actually still active and expanding. And that is why these terminal bulbs basically stain with rose Bengal stain. And that is the fundamental behind the difference of the staining in the two. Uh, at one point of time, when you stain the cornea, you may only find 1 or 2 active dendrites. However, actually, to be honest, there may be 4 or 5 dendritic lesions. The other may be in the process of being formed. So basically, once the ocular surface starts to break down and there's an active infection, it generally extends very fast. And the corneal sensations are absent wherever these lesions are there. Now, if left untreated, see, generally the epithelial keratitis or the dendritic lesions are self-limiting, and they spontaneously heal in 2 to 3 weeks. In few cases, wherein there is an injudicious use of topical steroids, if a topical steroid has been started in a case of dendrite, or in an immunocompromised patient with an underlying debilitating disease, there may be various linear dendrites which may coalesce to each other and form a very broad area, which is known as a geographic ulcer, right? So geographic ulcer is nothing but a form of dendritic ulcer which has progressed. Now, how would you generally differentiate between a geographic ulcer and a neurotrophic keratopathy? Because a neurotrophic keratopathy is very, very common secondary to an herpes simplex infection. So how would you differentiate? Because both a geographic ulcer and a neurotrophic keratopathy is very broad-based, covers a large surface area. So how would you differentiate? Ankita, who can answer this?
Sir, the edges will be scalloping if it is a if it is a geographic ulcer.
Right. And if it's a neurotrophic ulcer, then?
Sir, it will be punched out sort of.
Correct. May I know who's this? Who is answering?
Sir, Saloni.
Saloni, right. So Saloni, you are basically right. In a geographic ulcer, the margins will be scalloped because there is an active live virus here and the infection is basically spreading. On the contrary, in a neurotrophic ulcer, as you can see in this slide, the margins will be very well cut because these are rolled out edges. There is no active virus here. But the epithelial margins are unhealthy and the ulcer is not healing. On the contrary, in a geographic ulcer, the ulcer is spreading, right? So that's the basic difference, and that helps you. So if you stain the ulcer and you keenly watch the margins, you can clinically very easily differentiate between the two. So HSV epithelial keratitis, as we discussed, the epithelial lesions generally resolve spontaneously within 2 to 3 weeks. So the whole, I think there's some noise behind. I think we need to mute cancel the background noise. Thank you. Thanks, Saloni. So the epithelial keratitis generally resolves in 2 to 3 weeks by itself. So the whole rationale for treatment is to decrease the damage to the cornea. Also, if we do not treat it, these live virus may actually lead to more amount of stromal recurrences. So basically, you can give 1% trifluridine 8 times, 3% acyclovir eye ointment 5 times, and the new thing is ganciclovir 0.15%, again 5 times. All these 3 antivirals are toxic to the cornea. However, ganciclovir has been shown to have the least amount of ocular toxicity. But if used for beyond 2 weeks, all of this will lead to a toxic keratopathy or toxic medicamentosa, as we call it. As I already said, topical steroids absolutely contraindicated because they will cause further breakdown of the ocular surface and lead to geographic ulcers. Now, if the HSV epithelial keratitis has not healed, the patient is already on 2 weeks of treatment, he's on topical antivirals, but you are still able to see the lesion. You have to differentiate between a dendritic ulcer and a dendritic epitheliopathy, right? So as you can see this photo here, this was a patient who had come to my clinic. He was on topical 3% acyclovir eye ointment 5 times for the past 3 months. He was continuously using these medications for 3 months, and he still had a dendritic pattern here. When you stain this and you keenly look, it was a very lacy appearance, and thereby it was a epitheliopathy. It was more a neurotrophic pattern and not an active disease, because it did not have terminal bulbs. It was just that it was an epithelial regeneration line, what you call as a fusion line, and the lesion was just not able to heal completely because of constant breakdown, because of a toxic effects of the antiviral drugs. So either it can be a neurotrophic pattern or it can be a persistent epithelial infection. In those cases also, once you have given the drug for 2 weeks, it is better to stop it, because even if left untreated, it's a self-limiting disease and it will heal by itself. So there's no point continuing it more than 2 weeks, because then it becomes counterproductive and starts causing more damage than actual help. So that was about epithelial keratitis. It is the most common form of presentation, as I told you. Coming on to HSV stromal keratitis. Now, there are various questions about how to treat stromal keratitis, when to start oral acyclovir, when should we give a steroid, how long should we give it, when should we stop it. So to understand that, we first look at the lesions and then understand how to treat them. So HSV stromal keratitis, you have to understand there is no live virus. There is no activated virus. It is not an infection. It's only an immune mediated response of the host to the virus. So there has been an infection earlier. The virus was latent and has now got reactivated. Generally, you find that whenever you have high fever, you have cough, cold, URTI infections, or any other transient immunocompromised state, the virus gets reactivated. HSV stromal keratitis is the disease in the United States with the most severe visual morbidity. So let me tell you, it's very important to basically intervene at a very early stage so that you can give back a fair amount of vision to the patient. So HSV stromal keratitis, two types, non-necrotizing, necrotizing. We discuss the non-necrotizing types first. The interstitial keratitis. Now, interstitial keratitis can be focal or multifocal. So you can have various foci of infiltration, stromal infiltration, but there is no necrosis and there is no epithelial involvement. So no overlying ulceration, right? Now, the interstitial keratitis can have neovascularization. It's very common. And when these lesions regress, they will leave behind ghost vessels. Because of neovascularization, there can be deposition of lipids in the cornea at the tip of these vessels. And you can sometimes find antigen antibody complexes, something like an immune ring in the interstitial keratitis lesions. Now, basically, the HSV interstitial keratitis can be confused with other forms of interstitial keratitis, something like a sarcoid. The IK can be formed because of the varicella zoster. There can be a Lyme disease, a sarcoidosis, Epstein-Barr virus. So generally, the lesions are indistinguishable from each other. The disciform keratitis is a very common presentation of stromal keratitis. Now, these are central or paracentral lesions, round and oval, disc-shaped. You will find a stromal edema with an overlying epithelial edema and an underlying keratic precipitates, which may sometimes be underlying the active lesion and sometimes may be a little away and distributed from the lesion. Very important to note, there is no vascularization and no infiltration of the cornea. You may find very minimal AC reaction, but the stromal edema and the keratic precipitates are out of proportion to the reaction. Very minimal AC reaction. The AC reaction is much more in the necrotizing form of stromal keratitis. And the treatment of both these forms is different to each other, and so it is important to differentiate. It is very easy to differentiate also, because the disciform keratitis is not a very ghastly lesion, as I'll show you later in the slide on necrotizing. It's a very fulminant disease. Important, when you make a slit and you look, there is a clear demarcation between the involved and the uninvolved area. The disciform keratitis will resolve and leave behind a small scar, which will start fading away over a period of time. And So these are, so now you have slight variations of the disciform keratitis. You may see a diffuse endothelitis or a linear endothelitis. It is very, it mimics the, so these are basically subtypes or variations of the disciform keratitis. In diffuse endothelitis, you may see scattered capes all around, and the keratitis precipitates are not only limited to the lesion or the disciform area of involvement. Now, as I told you that in cases of recurrent stromal keratitis, you may have lesions in different parts of the cornea. So instead of a variation, basically these capes may be crenated old capes which have been left behind because of a previous lesion. So it is not necessary that these are attributed to this present active lesion. And so these may be old crenated capes which are left behind because of a previous inflammation. A linear endothelitis very rarely found, wherein the capes firstly start, the keratic precipitates start in the center and then start migrating towards the limbal area. And the peripheral corneal edema remains in the center. So you feel that the corneal edema is trailing the keratic precipitates. It's very similar to an endothelial rejection line or the Khodado's line, which we see in the cases of post-PK. So this is the necrotizing stromal keratitis. So what we have discussed till now in recurrent HSV keratitis is the non-necrotizing interstitial keratitis, non-necrotizing disciform keratitis, and now we have a necrotizing stromal keratitis. Now this is the only form of viral keratitis which has combined epithelial and stromal involvement. So it is correct. So this is a very fulminant lesion. As you can see, it's a very ghastly lesion on the eye, wherein you have an epithelial ulceration. You have heaped up epithelial cells, a lot of debris around the lesion. There is a stromal infiltration and there's a process of necrosis which has already started. So this is basically an active infection, whereas the virus is present. It has penetrated into the stromal layer, and the process of necrosis and colloquative liquefaction has already started. So there is an active viral replication here. If not intervened, then within a very short period, there will be thin. So these lesions can lead to severe thinning and lead to a perforation also. So the diagnosis mostly in these cases is a diagnosis of exclusion, because you keep on doing repeated scrapings and sending these scrapings for a gram stain and a KOH, and they keep on becoming negative. And then after a while, when 2 or 3 scrapings become negative, you take a small sample and send it for PCR, where it comes out to be positive, right? So this is about necrotizing stromal keratitis. It is very important to start topical steroids in this case very fast under the antiviral cover. Well, I'll be discussing about the treatment later on. Don't worry about it. And this is the final type of recurrent herpetic keratitis, which is HSV iridocyclitis. It can be granulomatous or it can be non-granulomatous. Because of the involvement, there's some background noise. Can somebody mute this? So there is involvement of the trabecular meshwork here. So there is a trabeculitis. Because of the edema of the network, the pores get clogged, and thereby there is an elevated intraocular pressure. Also, the iridocyclitis or the AC reaction tends to settle down and thereby clog the trabecular meshwork. If there has been a vascularization of the angle, a neovascularization of the angle, there will be some amount of hyphema also. And as you can see, this is called as candy can hypopion, which is very, very pathognomonic and typical of an HSV iridocyclitis. Generally, it has a unilateral presentation, and there is obviously a previous history of HSV ocular disease. So coming on to the treatment of the recurrent or reactivated HSV stromal keratitis. I think everybody knows, or at least has heard partly about the herpetic eye disease study. So before the herpetic eye disease study came, there were a lot of confusions about how to treat the stromal keratitis, and this helped us to give the answers to all these. So herpetic eye disease study, or HEDS, basically was a multi-centric prospective, randomized, double-masked, and placebo-controlled study. It was done in two phases, HEDS 1 and HEDS trial 2. HEDS trial 1 was from May 1989 to 1992. HEDS trial 2 was from October 92 to almost 90 to January 94. And there were a lot of collaborating centers. So there were 6 trials in all in both stage 1 and 2. There were 3 therapeutic, 2 preventive, and 1 cohort. So basically, I will not be discussing the inclusion criteria, exclusion criteria. I would be discussing what is important from a postgraduate point of view, which is the HEDS study answered 6 critical questions and cleared 6 doubts about treatment of stromal keratitis. And these are the questions which we always ask. The first question is, do topical steroids treat stromal keratitis, right? So there were 106 patients who were included in this study. They were divided into 2 groups. They were randomized to group 1, which received topical steroids, and group 2, which was on placebo for 10 weeks. The steroid started was 1% prednisolone 8 times every day per week, tapered gradually to 1 time per week. And both these groups were receiving topical trifluridine. So they were already on topical antivirals. And we were now trying to see whether the topical steroids were helping in early resolution of these lesions or not. The interpretation was that topical steroids did have a faster resolution of stromal inflammation and also had fewer treatment failures. So this provides a basis for the usage of topical steroids, namely 1% prednisolone 8 times every day to be tapered every week, along with topical antivirals in cases of stromal keratitis. The second most important question here is oral acyclovir helpful in treating stromal keratitis? And by this, I'm talking about non-necrotizing stromal keratitis, which is interstitial keratitis and disciform keratitis. Here, 104 patients were taken in the trial, randomized into 2 groups. One group receiving oral acyclovir, 400 milligrams 5 times, versus a placebo group. And both these groups were already receiving topical steroids and topical antivirals. And what we found was there was no beneficial effect of oral acyclovir in treatment of non-necrotizing stromal keratitis, right? So stromal keratitis improves rapidly only with topical steroids and topical antivirals, and there is no need to start an oral acyclovir. So now, is oral acyclovir helpful in HSV iridocyclitis or keratouveitis? That is where the uveitic component is also there. So 50 patients were treated with oral acyclovir 400 milligrams 5 times versus a placebo. Both these groups were already on topical steroids and antivirals. The number of patients who were taken in this trial were very less, and thereby the outcomes did not have a certain sense of certainty to it, but a non-statistically significant trend was found favoring the use of oral acyclovir in clinical doses. So what we conclude is that, yes, in clinical practice, it is better to add oral antivirals in their clinical doses along with steroids and topical antivirals when you find some kind of a AC reaction, some kind of iridocyclitis in the patient. So what do we do in necrotizing stroma? So this was about non-necrotizing stromal keratitis and about HSV iridocyclitis. Now what do we do in a necrotizing stromal keratitis, which is the most fulminant lesion? As I had shown you in the clinical photo, there was a lot of debris, heaped up epithelial cells overlying the lesion. So it is better to take a sterile cotton-tipped applicator and try and remove all this debris from the lesion, which is overlying the lesion. Start them on antiviral therapy, topical and oral in these cases. And once you feel that after starting the topical antivirals, the ocular surface has become slightly better, then start on topical steroids in 2 to 3 days. Do not wait for the epithelial lesion here to heal completely. Just start topical steroids. These diseases beautifully respond to topical steroids, even if 2 or 3 times a day. No role of systemic steroids here. So HSV necrotizing keratitis is the only indication where you would want to start topical steroids, number 1. and patient has to be on oral and topical antivirals 2 to 3 days prior to starting a steroid therapy. Now, does oral acyclovir prevent stromal keratitis and iritis in developing in epithelial lesions? So basically what we are trying to answer here was that if a patient has HSV epithelial keratitis or a dendritic ulcer, should we give them oral acyclovir? Because though they are not required in the active treatment of the lesion, but are they going to prevent further formation of or further recurrences of stromal keratitis? So here 287 patients were inducted of epithelial keratitis who received 3 weeks of oral acyclovir, 400 milligrams 5 times, which is the clinical dose, versus a placebo, and they were followed for almost 1 year. And what we found that there was no beneficial effect of starting oral acyclovir even in clinical doses in these cases. The best predictor for predicting whether you are going to have recurrences or not is the number of episodes you have already had. What that typically means is that more the amount of recurrences you have, more the amount of episodes you have, the more the chance of a recurrence. Starting an oral acyclovir will not reduce it in cases of dendrites. Now, does Acivir prophylaxis minimize HSV recurrences? Now, what you have to understand is this is not an active HSV infection. An active HSV disease is one of epithelial keratitis or a stromal involvement or iridocyclitis. Now, once the active infection resolves or an episode of reactivation or recurrence resolves and the patient is quiet, should you start acyclovir prophylaxis now so as to prevent recurrences? So 703 patients were taken in the trial here. And obviously they were divided into group A and group B. Group A received acyclovir tablet 400 milligrams only 2 times. And that's the prophylactic dose of acyclovir. Clinical dose is 5 times, prophylactic dose is 2 times versus a placebo. So this was given for almost 1 year, and then the patients were followed up 6 months after completion. So basically the follow-up period was almost 18 months. And what we found that oral acyclovir significantly reduced the probability of recurrence in prophylaxis group. So once an active lesion or an active infection has healed and the eye is in a quiescent stage, it makes sense to start oral acyclovir because it will reduce the probability of recurrence, right? However, the protective effect did not persist once this oral acyclovir was stopped. But once the eye is quiet for almost a year, when you have started the prophylaxis, the chances of recurrence tend to come down because most of the attenuated virus which the body already harbors is shed in these cases. And the last question which the HEDS answered was what triggers the recurrences. So here again, patients were recruited and they were asked to maintain a logbook and fill a questionnaire for almost 52 weeks, which is almost a year. They had to keep a log of all the illnesses which they have had, all the injuries, the emotional stressors, to try and find if there is any association between the reactivation and the psychological factors which a patient goes through, and no association was found. It was not a statistically significant association, but however, there is a hypothesis which states that stress and stressors tend to bring down the immunity of the body and there can be recurrences. So that's a very traditional hypothesis or approach. The HEDS did not find anything which was statistically significant here. So this was about, so what the HEDS told us was about the role of steroids, role of oral acyclovir in cases of stromal keratitis. Where should we start steroids? Where should we start oral acyclovir, and where they are, and where a topical antiviral is enough or sufficient. Now there have been 3 trials in this decade which has tried to study the role of cyclosporins in stromal keratitis. These are lesions of stromal keratitis which were unresponsive to topical steroids. Now, as you know, cyclosporin is also an immunomodulator. It inhibits the activation of T helper cells. It tries to block the production of inflammatory cytokines. Now, these cytokines are basically responsible for corneal vascularization, which increases the inflammation. and they inhibit this. Cyclosporin has been established as a treatment modality for the dry eyes and basically also for VKC. So any disease which has some kind of a subclinical inflammation there, does the cyclosporins have a good role in treatment, and which is also the case in HSV stromal keratitis, where some amount of subclinical inflammation always exists. So logically, conceptually, cyclosporin should have a role. Also, the adverse effects of steroids like cataract formation, glaucoma, all is obviated. So, but these three trials were not very conclusive, and I think there can be better trials which can substantially prove the role of cyclosporins. Now, role of amniotic membrane in stromal keratitis. Now, frankly, there is no role of amniotic membrane in non-necrotizing stromal keratitis because they respond well to steroids. Now, in cases of necrotizing stromal keratitis, which is a combined epithelial and stromal disease, they are very difficult to manage. Now, as I already showed in my previous slides, you must first start the patient on topical and oral antivirals, wait for about 2 to 3 days, and then start them on steroids. These lesions progress very quickly, they thin down very fast, and they perforate very fast. We know that amniotic membrane, the amniotic membrane does have certain growth factors in it, which promotes healing of the corneal epithelium. They have anti-angiogenesis factors as well, which inhibits corneal vascularization, reduces the scarring also, and thereby again AMG does have a role in treatment of necrotizing, wherein you find that there's an impending perforation. If you find that the cornea is about to perforate, it does need some kind of a tectonic support. It is better to do an amniotic membrane graft than to do a tectonic PK because the eye is inflamed. So it is better to do an amniotic membrane in these cases. However, one clinical problem which you may have is that AMG also interferes with the penetration of the drugs. So the topical antivirals and the topical steroids may find it difficult to penetrate, but then you have to weigh the benefit and the risk ratio. What I generally do is that in these cases, I do an AMG and give a subconjunctival steroid in these cases, which keeps on acting for about 2 to 3 days till the time the AMG also starts the process of disintegration. The AMG generally disintegrates completely in 10 to 14 days. So the AMG starts disintegrating, thinning out, and then the percolation of the drops also becomes better. So this was about the recurrent or the stromal keratitis, HSV stromal keratitis. Now we discuss about neurotrophic keratopathy, which is also called as ulcer metaherpetica or metaherpetic ulcer. It's a misnomer because it is not an active infection. So this is generally because of an underlying damage to the fifth cranial nerve, which leads to corneal hypoesthesia. It can also be caused because of the beta blockers, or if the patient is on chronic lubrication with preservatives. Mostly the BAK causes a lot of neurotrophic keratopathy. You may find pericentral pseudodendritiform lesions. So this is basically because of corneal hypoesthesia. The corneal sensitivity is very low. As a result, the ocular surface starts to break down. It doesn't heal very rapidly. These lesions are mostly found in the central part, which is the inferonasal part or the inferior part. This is because of a good Bell's phenomenon. When you try to close the eyes, the superior part of the cornea is nicely covered by the lids, but the inferior cornea is the one which is most commonly exposed to the environment. And that is why these kind of sterile melts or neurotrophic keratopathy or exposure keratitis lesions tend to happen in the inferior part of the cornea. So treatment, basically no antiviral drugs required here, no live infection. Frequent lubrication with non-preserved drops and ointments generally helps. In most of the cases, 80% of the cases, if you keep the patient on an hourly lubricants and a very dense viscous ointment, something like a Lacri gel or a Genti gel, it generally tends to help and heal the neurotrophic ulcers. Sometimes you may need autologous serum drops, 20%, because the serum has fibronectin, which is again a growth factor for the epithelium and tends to heal the epithelial lesions. In case after 3 to 4 weeks of therapy, if you feel that the ulcer is not responding and the dimensions remain the same, you can start thinking about a punctal occlusion. You can first do the punctal plugs, which is a temporary occlusion, so that you will understand that the punctal plugs are going to help or not, and then you can think about a permanent occlusion. You would want to do only the occlusion of one punctum, which is the upper punctum. The upper punctum drains only 10% of the tears, and that is why you want to occlude only the upper punctum. If you occlude the lower one, then the patient may start having watering and excessive lacrimation, and you may have to actually deal with another problem which you have created. A central tarsorrhaphy can also be done, but generally I do a tarsorrhaphy when I'm doing an AMG, a persistent epithelial defect. When I'm seeing that the cornea is thinning, there is a chance of a perforation, do an AMG and a central tarsorrhaphy, which helps us. A CXL is basically can be done because it tends to strengthen the cornea. However, it is still being studied, and there is no I've never done a CXL in a neurotrophic but there are people who are doing these kind of studies now. Very rarely, if the neurotrophic ulcers perforate and there is a perforation, if it's a small perforation less than 2 millimeter, you can do a tissue adhesive with a bandage contact lens. But if these are large ulcers more than 2 mm, then there is no other option but to do a tectonic PK or a patch graft in these cases. So this was about herpes simplex keratitis. The other thing which we have to discuss is herpes zoster ophthalmicus. It's a very small entity. So basically, varicella zoster virus is the same virus which causes a chicken pox. This establishes latency in the sensory ganglion, also the Gazerian ganglion. And there is again an endogenous reactivation of the latent virus, like the herpes simplex virus, when there is a waning level of immunity. Important is herpes zoster is most commonly found from 6th to the 9th decade of life. And it is very common in patients on immunosuppressive therapy who are on HIV treatment or after any major surgery. So basically, there has to be some kind of transient immunosuppression in these cases. You first of all find that the pain precedes any kind of lesions. So along the course of the nerve, basically, the trigeminal nerve, which is affected, there is a lot of pain. So there's a lot of neuralgia. Then start the skin lesions or the eruption. So this is a painful vesicular dermatitis. So skin eruptions start. It is generally localized to a single dermatome on the thorax or face. Most common is T3 to L3, right? All the 3 branches of the trigeminal nerve can be affected, but the most common is the ophthalmic division, which leads to an involvement of the eye, which is then referred to as HZO or herpes zoster ophthalmicus. Ocular involvement is found in more than 70% of patients with zoster, especially when the nasociliary branch of the ophthalmic division is involved. The first lesion is punctate lesions and not dendritic lesions. The most common lesions in HZO is punctate lesions. They can be focal or multifocal. They may coalesce and become a little deeper and may form patchy anterior stromal infiltrates, as you can see in the photo below. So these are the most common lesions, and if left untreated, they may lead to deeper lesions known as nummular corneal infiltrates. And these are characteristic of zoster keratitis. So dendrites are not very common. The nummular lesions are more common in cases of HZO keratitis. However, you can still find dendrites, and they are called as pseudodendrites. The differences are, in a herpes simplex, the dendrite is very fine and lacy. These are pseudodendrites, so they are broad-based, they are plaque-like, they are elevated mucus plaques, basically. There are no terminal bulbs seen here, which is very, very easily seen on a slit lamp, and thereby they do not get stained with rose bengal. They're very poorly stained. Now, oral antiviral therapy has to be started, ideally within the first 3 days of the onset of symptoms. Now, this can be oral acyclovir, 800 milligrams 5 times, or nowadays the prodrugs of acyclovir, which is valcyclovir or famciclovir. Any of these can be given for at least a minimum of 10 days. And what does it do is it helps to reduce the viral shedding from the skin lesions, decreases the incidence of post-herpetic neuralgia also. So there have been various studies, and the dipeptide prodrugs, mainly valcyclovir and famciclovir, have been found to be better than the parent drug, which is acyclovir. Now, because of widespread use of acyclovir in the treatment of genital, orofacial, all kinds of herpetic lesions, it is very easily available over the counter. And that is why acyclovir resistance is now being seen. But then this is more common in immunocompromised patients, not so in the immunocompetent patients. In immunocompetent individuals, the immune system basically drives the virus into a latent stage. So it becomes an attenuated virus, it is harbored in the ganglion, and it is not very active. In immunocompromised, the virus is still present in the lesions, it is exposed, and thereby it gets a chance to develop the resistance. Now, what are the indications for penetrating keratoplasty after herpes simplex keratitis, both zoster as well as the HSV keratitis? No, generally in the sequelae of HSV keratitis, if it's a significantly scarred cornea because of multiple recurrences, what you have to understand is that every recurrence, whenever it happens, leads to increase in the scarring of the cornea and leads to visual diminution. The morbidity tends to increase. The incidence of vascularization is more because of repeated infections. Incidence of lipid keratopathy is more, and thereby you may have to think about a PK in these cases. But PK in cases of viral keratitis has more post-op complications as compared to other indications. There are more chances of a recurrence. So you may find a HSV keratitis recurrence on the graft. There is low corneal sensitivity, so chances of neurotrophic keratitis in these grafts. Chances of more corneal vascularization. So what are the three things which you must remember to good visual outcome in these cases? First of all, never do continuous suturing. Always do and find interrupted sutures, because if the one of the sutures has loosened down or there's a recurrence or involvement of graft host junction, you will be able to remove these interrupted sutures. In cases of continuous, you will have to remove the whole sutures. The acyclovir prophylaxis is important. It should start 6 months prior to when you are planning to do a surgery and should continue at least 1 year after you have done a PK, and use intensive post-op steroids. Still, the recurrence rates can vary from 12 to 27%, which is a high chance of incidence. And this was a study done at Cochrane, which also came up with it. So they did 3 trials, involved 126 participants, and came up with the same conclusion that oral acyclovir given in the clinical doses given in the therapeutic doses lowers the chances of a recurrence of HSV keratitis on the grafts. So this was about HSV keratitis and herpes zoster ophthalmicus. A very small entity is the adenoviral keratitis. Now, as we discussed the morphology of herpes virus, they are lipid enveloped viruses, and thereby they are very short-lived outside the host, and they get very easily denatured by alcohols and detergents. Adenovirus does not have a lipid envelope. It is far more resistant to alcohol and detergents, and that is why the most common type of hospital-acquired infections or nosocomial infections is adenoviral keratitis, or the EKC as we call it, epidemic keratoconjunctivitis. It generally involves the conjunctiva. In severe cases, it may lead to the involvement of the cornea, which is stage 1, 2, 3, 4. The 4th stage is visually debilitating, where there may be nummular opacities, which are subepithelial. In herpes zoster ophthalmicus, these opacities are anterior stromal. In adenoviral, they are subepithelial. So it is very important to intervene in herpes simplex infections early. They can really impair your quality of life, as was this study done and published, wherein 33 patients were assessed on their quality of life versus 66 patients who had no history. So even during a quiescent phase where they did not have an active infection, when there was no recurrence, the quality of life went down on various parameters. The herpes infections causes visual morbidity, brings down your social function, mental health, makes you dependent on the other family, and thereby it is very important to understand the concepts and intervene on an early basis. Thank you.
Thank you so much, sir,
Thank
for
you.
such an elaborative class on viral keratitis. There are few questions, sir,
Yes,
and
please,
all of them on the treatment management. So I'll take one by one.
please go ahead.
The first one is there any role of topical antiviral drug in cases with only stromal component of the viral keratitis?
No, a role of topical antivirals in
Yes, sir. In viral keratitis, which is
in
just,
what? Can you repeat?
yes, sir. Is there any role of topical antiviral drug in viral keratitis, which is just having a stromal component, not an
Yes, yes.
epithelial component?
Correct. Yes. So as I discussed, as the HEDS, the herpetic eye disease study forms the basis of treatment in all these cases, and they very clearly said that topical antivirals has to be given along with topical steroids in both necrotizing as well as non-necrotizing cases. The whole idea there is that this live attenuated virus is sometimes shed in very minute quantities during the course of the treatment, and thereby a topical antiviral may help it. There is no role of oral antivirals in stromal keratitis. Role of oral lies only when there is an underlying iritis, iridocyclite entities.
Okay, so you covered the second component also. The second was that only. What is there any role of oral antiviral? Okay, the next question
Right.
is, sir, how should tapering of topical steroids should be done in stromal keratitis?
Yes, again, that has been answered by the HEDS study. What we follow, generally we start 1% prednisolone 8 times per day, because that is what was started in the HEDS, which was followed in the HEDS. 8 times per day for a week with tapering till it comes down 1 time. So 8, 6, 4, 3, 2, 1.
Sir, I think there is some network issue.
Ankita?
Yes, sir. Your voice got broken, sir, at the end.
Should I
Your
repeat?
voice got, yes, sir, yes, sir.
Should I repeat?
Yes, sir. Yes, sir.
Okay, no problem. Basically, again, the role of topical steroids, again, as enumerated by HEDS. So, see, basically, the herpetic eye disease study is a beautiful study. It's almost like a theorem. You know, it is like a formula. You identify the lesion and then you apply the formula to it. That's it. Then and you know that's about it. So very simple. HEDS says topical steroids. They started as 1% prednisolone 8 times per day, tapered it to 6, 4, 3, 2, 1 over every week, and so you started for 6 weeks.
Yes, sir. Then the next question is, should we start prophylactic oral antivirals in patient with history of recurrent HSV keratitis who want to undergo cataract surgery?
Yes, of course. So,
and what should be the dose for that, sir?
Correct. See, very clear. Again, the clinical dose is 400 milligrams 5 times. Prophylactic dose is 400 milligrams 2 times, right? So wherever there you want to start oral acyclovir in iridocyclitis or an active lesion, and in the iridocyclitis or the necrotizing disease, you have to give the clinical doses. Prophylactic doses 400 milligrams BD. In cases of PK or a corneal transplant, as a study has clearly stated, you started 6 months prior to planning a surgery. In cataract, I generally do it a week prior to the surgery. So I start 400 milligrams BD 1 week prior to a cataract surgery and then continue it for another 2 weeks. So 3 weeks of the oral acyclovir.
Yes, sir. So in case of recurrent viral keratitis, what should be the dosage and for how long should we use oral acyclovir?
In cases of recurrent keratitis, what should be the dosage?
Yes, sir. And for how long we should use?
Yeah. So again, see, yes. So oral acyclovir in recurrent stromal keratitis, you have to give clinical doses 400 milligrams 5 times a day for 3 weeks.
Okay, sir. Sir, role of systemic steroids in viral keratitis.
This is a very interesting question, very nice question, because there's a lot of controversy on this, what to do. Practically, there is no role of systemic steroids in any of these lesions. Some people feel, and there are some studies which have not conclusively proved, but state that in cases of necrotizing stromal keratitis, wherein there is a combined epithelial lesion and a stromal involvement, where there is a stromal keratolysis going on, the cornea is thinning, there is an impending perforation. You have put an amniotic membrane graft on top, and you feel that the topical drug may not penetrate very nicely, you can start oral steroids in these cases, but you must try to rule out, but you must take a physician clearance. So rule out any underlying tuberculous lesions or anything. And of course, you have to look for, if the patient is diabetic, you have to look for the sugar level. So a physician clearance, and you can start in those cases, because the oral drug may penetrate more compared to a topical drug.
Okay, sir. And can we replace acyclovir with valcyclovir?
Yes. The valcyclovir is now being preferred to acyclovir, because the valcyclovir is to be taken only 3 times. The dose is 1 gram TID, or 3 times, as compared to acyclovir, which is to be given 5 times. Hence, the patient compliance improves in these cases. But you have the side effects are, thrombocytopenic purpura, hemolytic uremic syndrome. So you will have to keep on doing the liver function tests and be a little more vigilant. But then valcyclovir is given only for about 1 week to 10 days again. So yes. So nowadays valcyclovir is basically replacing acyclovir.
Okay, sir. And is ganciclovir better than acyclovir?
Topically, you see, ganciclovir topically is better because it is less toxic to the cornea. But then every topical antiviral is toxic, causes toxic medicamentosa. Ganciclovir has shown to be better, but not devoid of it.
Okay, sir. Is there any role of oral acyclovir in interstitial keratitis and treatment of interstitial keratitis caused due to herpetic keratitis?
No. So this has basically been answered by HEDS.
HEDS.
Interstitial keratitis forms a spectrum of the non-necrotizing stromal keratitis, which is treated beautifully with topical steroids and topical antivirals. So no role of oral is. So basically, this is very typical. Whenever I talk on viral keratitis or I attend, all questions are on the HEDS or treatment of stromal keratitis.
So the next question is also like that. Is there any role of topical acyclovir on adenoviral keratitis?
No, generally no. Basically, the EKC or adenoviral keratitis is generally present as a follicular conjunctivitis. We start on antibiotics and lubricants. If you see epithelial punctate lesions or epithelial keratitis, as they have 4 stages, 1, 2, 3, 4. You want to start there on the steroids. So topical steroids are indicated for adenoviral lesions.
Okay, sir. Then coming to toxicity, there is one question that all the antivirals are toxic after 2 weeks. Correct. Then if HSV viral keratitis, if it is persistent, then how to manage that, sir?
Nice. Very good question. So again, you continue the topical antivirals for 2 weeks. And then if you still find a lesion, you can actually just untreat. You can just start the patient on lubricants and just leave it, because these lesions because anyways, the dendrites and these lesions are self-limiting. They tend to heal by themselves. So the amount of toxicity which these drugs will create, or the ocular surface breakdown they will cause, basically outweighs the benefits of keeping them on longer. So eventually this lesion will heal by itself. And whatever the role of antiviral was, it has done. It has basically been started to cause less inflammatory damage to the cornea, which it has already done. So 2 weeks is enough. Then you just stop it and leave the lesion. It will heal by itself.
Okay, sir. Now there are a few questions on clinical features. First is, what is the difference between recurrent and reactivation of herpes keratitis?
It's the same thing.
Yeah. The second one is how to differentiate nummular opacities of herpes zoster ophthalmicus and adenovirus keratitis early by the clinical signs.
Very good. So again, it's basically a slit lamp evaluation. As I told you, in cases of herpes zoster, these lesions are slightly deeper. They are anterior stromal. On the contrary, in adenovirus, these lesions are subepithelial, so they are more superficial. And this is where we have now actually started to do ASOCT. So the ASOCT tends to help us. Initially there was a lot of confusion, and now this is a clinical application wherein we do an ASOCT and try to differentiate the depth of the lesion, and that helps us.
Okay, sir. These all are from Facebook and YouTube. Any hot seaters, you have any question, you can directly ask, sir. Or sir can also ask them.
No, my turn to ask is gone. No, it is already. I have already finished my turn. I should have.
There are some questions here also. Nikita?
Yes, sir. Done, sir. Done, sir. Taken on.
Fine.
Take more. No point.
So what are the specific indications for starting steroids in adenoviral conjunctivitis?
Yes. See, basically, the concept here says that if you start topical steroids very early in adenovirus, it tends to make, beat the virus, the latency of the virus increases. So there are more chances of having repeated, reactivations of the adenovirus. So if the infection does not involve the cornea, it is only conjunctival, you have a follicular presentation, better not to start the steroid. The steroid should be started once there is a keratopathy. The moment you have a corneal involvement, then you start it, because you don't want these lesions to become subepithelial and leave behind permanent scars, which may cause the vision to drop. But so basically, I have seen many patients in which have only a conjunctival involvement and steroids are started. So you are basically not helping the patient. You are actually increasing the chances of recurrences. But once there is a corneal involvement, then you start the steroids in these cases.
Ankita, there are a couple of questions, no? On
Taken, sir. Take it.
that's all?
Yes, sir.
Okay. Sure?
Yes, sir.
Checked on that.
Ankita is basically grilling me like a CBI or the
Right. Despite being COVID positive, she's grilling everyone.
I'm not COVID.
Suspected.
So there is one more question which has come right now. Role of oral antiviral in epithelial keratitis.
No role.
But you have already discussed this. No role, yes, sir.
No role, absolutely no role.
Great then. Varun, thank you so much. Very wonderful. Really wonderful class.
Thank you, sir, for the opportunity.
Very detailed. Thank you so much.
Thank you, sir.
So on Friday, we will have Dr. Savitri Sharma covering microbiological aspects of infectious keratitis. So she will cover bacterial, fungal, and viral, and all the standard microbiological procedures plus molecular biology techniques, which will help us diagnose microbial keratitis. So that will be a very useful lecture. She's an ophthalmic microbiologist and a very good one at that from LV Prasad Institute. So please be there Friday, 8 o'clock. Thank you then. Good night.
Yes, sir. Good night. Good night.
Good night, sir.
Bye.
Bye, sir. Bye, sir. Thank you.